Welcome to the deep dive. Today, we're zeroing in on a really vital tool for understanding the heart, the electrocardiogram. You probably know it as the ECG.
That's right. It's non-invasive, but it gives us this incredible window into the heart's electrical activity.
Exactly. And for those of you, just starting your medical journey, maybe feeling a bit overwhelmed by it, this deep dive is really for you. We want to demystify the basics.
Precisely. The ECG basically translates all that electrical activity, that sort of hidden dance inside the heart, into waveforms we can actually see and analyze.
And these patterns, they're packed with information, right? Clues about arrhythmias, problems with blood flow, even electrolyte imbalances.
Oh, definitely. It's an amazing diagnostic tool. And
Yeah.
it's got history, too. The first telecardiogram was way back in 1903, believe it or not. Still absolutely crucial today.
Okay, so let's start to make sense of those squiggly lines. They can look a bit like, well, abstract art if you don't know what you're looking for.
Heh, they can. Our goal today is to give you a really solid, structured way to understand it.
Right. So we'll cover where to put those sticky electrodes, proper placement, and then we'll explore the 12 different views or leads they give us.
Then we'll get into the heart's own electrical wiring, the conduction system,
Yeah.
and finally decode the actual waves, the P wave, the QRS complex, the T wave.
They really want to build that foundation so you can look at an ECG trace with, a bit more confidence, not just panic.
Exactly. And the absolute first step is getting those electrodes in the right place. That's the bedrock.
Right. So a standard 12-lid ECG, it uses 10 electrodes, which always sounds a little funny. 10 pads, 12 views.
It does, but it works. The machine does some clever math. Let's start with the chest electrodes first, the precordial leads. There are 6 of them.
Okay, where do those go? Let's walk through it.
Okay, V1. That one goes in the 4th intercostal space. So count down 4 spaces between the ribs right next to the sternum, breastbone, on the right side.
Fourth space, right edge of the sternum. Got it. V2.
V2 is its mirror image. Same space, 4th intercostal, but on the left side of the sternum, directly across from V1.
Okay, easy enough. V1, V2, opposite sides. What about V3? Does it just slot in next to V2?
Not quite. You actually place V4 first. V4 is a key landmark. It goes to the 5th intercostal space, so 1 space lower, right in line with the middle of the clavicle, the collarbone. That's the midclavicular line.
Okay, V4. Fifth space, midclavicular line. Then where does V3 fit in?
V3 goes exactly midway on a straight line between V2 and V4. So you find V2 and V4, then put V3 right in the middle.
Right, splitting the difference. Makes sense. So that's V1, V2, V3, V4. What about V5 and V6?
V5 goes on the same horizontal level as V4, but further around the side on the anterior axillary line. That's basically the line dropping down from the front fold of your armpit.
Same level as V4, front of the armpit line,
Yep.
and V6.
V6 is also on the same horizontal level as V4 and V5, but even further around on the mid-axillary line, the line straight down from the middle of the armpit.
Gotcha. V4, V5, V6, all in a row, horizontally, just moving around the side of the chest. So that's the 6 chest leads sorted.
Yeah, those give us the horizontal plane view. Now for the limb electrodes, there are 4 of those.
Okay, arms and legs, right.
Exactly. RA for right arm. You can put it anywhere really between the shoulder and the elbow. Just avoid big muscles if you can.
Okay, RA, right arm.
Then LA for left arm, same idea, between the left shoulder and elbow.
LA, left arm, easy.
Then RL for right leg, that goes somewhere below the torso, above the ankle on the right side.
Right leg, RL.
And finally LL for left leg. Same place, below the torso, above the ankle on the left side.
Okay, 6 on the chest, 4 on the limbs, 10 electrodes total. Now, how do these 4 limb electrodes give us 6 different views? That's the confusing bit sometimes.
Right. So the ECG machine uses these 4 limb electrodes, RA, LA, LL, and RL, to create 6 different views of the heart's electrical activity in the vertical or frontal plane.
Frontal plane.
These are leads I, 2, 3, and then 3 others called AVR, AVL, and AVF.
ICI 3, AVR, AVL, AVF. 6 leads from 4 electrodes.
Exactly. Leads 1, 2, and 3 are called bipolar leads. They measure the electrical difference between 2 specific limb electrodes.
Okay, like lead eye measures between the right arm and left arm.
Precisely. Lead I is LA minus RA, lead 2 is LL minus RA, and lead 3 is LL minus LA.
And this is where Einthoven's triangle comes in, right? That diagram you always see.
You got it. Einthoven figured out this relationship. Those 3 leads, I, 2, 3, form an equilateral triangle around the heart using the RA, LA, and LL points.
Makes a nice visual. What about AVR, AVL, and AVF? You said they were different.
Yeah, those are the augmented leads, and they're unipolar. Think of them as looking towards the heart from one specific point. The right arm, AVR, the left arm, AVL, or the left leg, AVF.
And what's the reference point they're measuring against?
The machine calculates an average reference point from the other two limb leads, so they look from one direction relative to a central point.
Okay, that clarifies the unipolar idea. And what about the fourth limb electrode, the right leg one, RL? What's its job in all this?
The RL lead is basically just a ground. It doesn't contribute directly to forming those 6 leads, but it's really important for reducing electrical interference, artifact, noise on the tracing. Helps keep the signal clean.
Crucial for getting a good reading, then. Okay, so we've got the electrodes placed. We understand how they give us these 12 different perspectives. Now, let's dive into the heart itself. Its electrical system is pretty unique, isn't it? It doesn't just wait for signals from the brain.
That's a really key point. The heart has its own built-in electrical conduction system, and importantly, it's made of specialized heart muscle cells, myocardial cells, not nerve cells like you might think.
So these heart cells can actually create and send electrical signals.
Yes, they have this property called automaticity and conductivity.
And the leader of this whole electrical operation is the SA node, the pacemaker.
Exactly. The sinoatrial node, or SA node, it's tucked away up in the wall of the right atrium. Its cells naturally fire off electrical impulses faster than any other part of the heart, so it sets the pace.
So the impulse starts there. Where does it go next?
From the SA node, the electrical wave spreads out across both atria, the top chambers, causing them to contract. Then, the signal converges at another critical spot called the atrioventricular node, the AV node.
But AV node, is that like a checkpoint?
Sort of, yeah.
Yeah.
It acts like a gatekeeper. It actually slows down the impulse just for a fraction of a second. This delay is important. It gives the atria time to finish contracting and push blood into the ventricles before the ventricles get the signal to squeeze.
Ah, clever timing. So after the AV node delay,
Then the impulse travels rapidly down through the His-Purkinje system. That's a network of fast-conducting fibers, the bundle of His, the bundle branches, and the Purkinje fibers that spreads the signal throughout the walls of the ventricles, the main pumping chambers.
and that makes the ventricles contract in a coordinated way.
Precisely. A synchronized, powerful contraction to pump blood out to the lungs and the rest of the body.
Okay, so we have this electrical pathway. Now, when we look at the ECG, are we seeing the electricity zipping through the SA node and the His-Purkinje fibers direct?
That's a really common misconception, actually. The electrical activity of the conduction system itself, the SA node, AV node, his bundle is tiny. It's too small for our surface electrodes to pick up directly.
Really? So what are we seeing on the ECG then?
What the ECG records is the much, much larger electrical event of the depolarization and repolarization of the bulk of the heart muscle cells, the atrial and ventricular myocardium as they respond to that signal from the conduction system.
Okay, so it's not the spark, but the big explosion it triggers in the muscle.
That's a great analogy. You don't see the tiny wire carrying the current to the dynamite, but you definitely see the building collapsing when the dynamite goes off. The ECG sees the building collapsing, the mass depolarization of the heart muscle.
That makes a lot more sense. So it's the collective electrical activity of all those muscle cells. You mentioned depolarization. Can we quickly touch on what's happening at the cell level there?
Sure. So a resting heart muscle cell has a negative charge inside compared to the outside. This is maintained by ion pumps, mostly moving sodium out and potassium in.
Okay, negative inside.
When the electrical impulse arrives, it triggers gates, or channels, in the cell membrane to open, allowing positive ions, mainly sodium, to rush into the cell.
Sodium rushes in.
Right. This flood of positive charge reverses the cell's polarity. It becomes positive on the inside. That's depolarization.
And that electrical change makes the muscle contract.
Almost. The depolarization triggers another event, the release of calcium ions stored inside the cell from the sarcoplasmic reticulum. It's this release of calcium that actually interacts with the contractile proteins actin and myosin, causing the muscle fiber to shorten and contract.
Wow, it's a neat chain reaction. Electrical signal ion movement, calcium release, MES contraction?
You've got it. And then repolarization is the process of the cell restoring that negative charge inside, getting ready for the next beat.
Brilliant. Okay, so now let's link this back to the actual ECG tracing. We see these bumps and spikes, the P wave, QRS complex, T wave. What do they represent?
Right, these are the main components. First up is the P wave. It's usually the first little rounded bump you see.
Okay, P wave.
The P wave represents atrial depolarization, the electrical signal spreading through the atria, leading to their contraction.
So P wave equal activation. What comes next?
Next, usually after a short flat line, you get the QRS complex. This is typically much larger and sharper than the P wave.
The big spiky bit.
Yeah. The QRS complex represents ventricular depolarization. the electrical signal spreading rapidly through the ventricles, causing them to contract. It's bigger because the ventricles have so much more muscle mass than the atria.
Makes sense. More muscle, bigger electrical signal. So P wave for atria, QRS for ventricles depolarizing. Then there's the T wave.
Correct. The T wave comes after the QRS complex, usually a broader, smoother bump. This represents ventricular repolarization, the ventricles electrically resetting themselves after contraction.
Ventricular recovery. Is there a U wave sometimes too?
Occasionally, yes. A small, rounded U wave can sometimes be seen after the T wave. Its exact origin is still debated, but it's often thought to represent repolarization of the Purkinje fibers or papillary muscles. It's not always visible, and usually its absence isn't a concern.
Okay, so P, QRS, T are the main players. P, atrial depolarization, QRS, ventricular depolarization, T is ventricular repolarization. What about atrial repolarization? Where's that?
Good question. The atria do repolarize, of course, but that electrical event happens at the same time as the much larger ventricular depolarization, the QRS complex.
The QRS just hides it.
Exactly. The electrical signal of atrial repolarization is usually completely buried within the large QRS complex, so you don't typically see a separate wave for it on a standard ECG.
Clever. Okay, now what about the flat lines and the timings between these waves, the intervals and segments, like the PR interval?
Yes, those are critically important too. The PR interval is measured from the beginning of the P wave to the beginning of the QRS complex.
Start of P to start of QRS. What does that time tell us?
It represents the time it takes for the impulse to travel from the SA node through the atria, pause in the AV node, and to start activating the ventricles. Basically, AV nodal conduction time.
And is there a normal range for that? Can it tell us if something's wrong?
Absolutely. A normal PR interval is typically between 0.12 and 0.20 seconds, so about 3 to 5 small squares on the ECG paper. If it's too short, say less than 0.12 seconds, it might suggest the impulse is bypassing the AV node through an accessory pathway, like in Wolff-Parkinson-White or WPW syndrome.
Which can cause problems like fast heart rates.
Exactly.
Yeah.
And if the PR interval is too long, consistently over 0.20 seconds, that indicates a delay in getting through the AV node. That's first-degree AV block.
Okay, so PR interval tells us about conduction from atria to ventricles. What about the QRS duration, the width of that QRS complex?
The QRS duration measures how long it takes for the ventricles to fully depolarize. Normally this is quick, less than 0.12 seconds, usually between 0.06 and 0.10 seconds.
So a narrow QRS is generally good.
Generally, yes. It implies the conduction down the air. His Purkinje system is fast and efficient. If the QRS is wide, say wider than 0.12 seconds, it means ventricular depolarization is slowed down.
And what could cause that?
Common causes include a block in one of the bundle branches, a bundle branch block, or if the heartbeat actually originates from the ventricles themselves, like in ventricular tachycardia or a PVC, instead of coming down from the atria.
Got it. Wide QRS often means trouble in the ventricles or the conduction system below the AV node. What about the QT interval?
The QT interval is measured from the start of the QRS complex to the end of the T wave. It represents the total time for ventricular depolarization and repolarization, essentially the entire electrical systole of the ventricles.
Okay, start of QRS to end of T. And why is that important?
Its length is crucial. Both a significantly prolonged QT interval and, less commonly, a very short QT interval can increase the risk of dangerous ventricular arrhythmias, like torsades de pointe. Lots of medications can affect the QT interval, so it's something we watch closely.
Right, medication side effects are a big one there. Okay, and then there's the S-key segment, the bit between the QRS and the T wave, and the J point.
Yes, the J point is literally the junction point where the QRS complex finishes and the ST segment begins. The ST segment itself is that usually flat line between the J point and the start of the T wave.
Is it supposed to be flat?
Ideally, yes, it should be close to the baseline, the isoelectric line. This period represents the time when the ventricles are fully depolarized, plateau phase, before they start to repolarize.
And changes here are important.
Hugely important, especially in suspected heart attacks. ST segment elevation, where the segment is lifted significantly above the baseline, can be a sign of acute myocardial infarction, ongoing heart muscle injury. ST depression, where it's pushed below the baseline, can indicate ischemia, meaning the heart muscle isn't getting enough oxygen.
But it's not always a heart attack, right?
Correct. You can see ST changes in other things too, like pericarditis, electrolyte problems, or even sometimes as a normal variant called early repolarization, especially in young, healthy people. Context is key.
Absolutely. Okay, this is building a great picture of what each part means. So for a student looking at a strip, how do they put it all together? Is there a system?
Yes, a systematic approach is absolutely essential. Trying to spot abnormalities randomly is a recipe for missing things.
What does that system look like generally?
Well, first, you always check the basics: patient name, date, time, and the calibration signal on the ECG itself to make sure it's technically adequate. Then you look at rate, how fast is the heart beating. Then the rhythm, is it regular or irregular?
Rate, rhythm. What's next?
Then you look for P waves. Are they there? Is there one P wave before every QRS complex? Are they all shaped the same? Then measure the PR interval. Then assess the QRS duration. Is it narrow or wide? Then look at the QT interval. And finally, scrutinize the ST segment and T waves for any abnormalities like elevation, depression, or inversion.
And axis too, right? Although maybe that's a bit more advanced.
Axis is important too, yes. Determining the overall direction of electrical flow. That's often part of a detailed analysis. But starting with rate, rhythm, P waves, PR, QRS, QT, STT waves is a solid foundation.
And a crucial point you made earlier, the ECG shows electrical activity, but not necessarily effective pumping.
Exactly. That's vital. You can have situations like pulseless electrical activity, PEA, where the ECG shows an organized rhythm that looks okay, maybe even normal sinus rhythm, but the patient has no pulse because the heart isn't mechanically contracting effectively.
Or VFib, ventricular fibrillation, where there's chaotic electrical activity but no coordinated pump at all.
Right. The electricity is there, but the mechanics aren't working. Always correlate the ECG with the patient's clinical condition.
Good point. Now, sometimes the tracing itself isn't very clear. You get interference, right? Artifacts.
Oh yes, artifacts are the bane of ECG interpretation sometimes. They're basically any electrical signal on the ECG that isn't coming from the heart itself.
What causes them usually?
Lots of things. Loose electrodes are a big one if the pads aren't sticking well. You get baseline wander or erratic signals. Patient movement is another. Shivering, tremors, even just deep breathing can make the baseline go up and down.
Muscle tension too.
Definitely. Tense muscles create electrical noise. And then there's electrical interference from other equipment in the room, like monitors, infusion pumps, sometimes even fluorescent lights or mobile phones.
I remember hearing a story about someone brushing their teeth, and the movement artifact looked just like V-Touch on the monitor.
That's a classic. Skeletal muscle artifact can absolutely mimic dangerous arrhythmias. It really highlights why you need to look closely, see if there's an underlying rhythm trying to peek through the noise, and always check the patient.
So minimizing artifact is key. How do we do that? Good skin prep.
Absolutely paramount. The skin needs to be clean, dry, and free of oils or lotions. Shaving excessive chest hair where the electrodes go is often necessary for good contact.
Gently rubbing the skin sometimes helps.
Yes, a little abrasion can reduce skin impedance. Using fresh electrodes with good gel is also important. And making sure the cables aren't pulling on the electrodes. Securing lead wires can help.
So a bit of care during setup saves a lot of trouble later. Are there other, less common types of artifact we might see?
Yeah, with more implanted devices now, you might see artifact from pacemakers. You'll see pacing spikes. Or sometimes from neurostimulators like deep brain stimulators or spinal cord stimulators. They can create unusual patterns.
And you mentioned something about pacing causing echo distortion.
Right, with transcutaneous pacing through pads on the skin, you see the pacing spike. But sometimes the electrical capture can look distorted, called echo distortion artifact, which you need to differentiate from the patient's own QRS.
And loose limb lead can mess up more than just one lead reading.
Yes, because of how the leads are calculated. For instance, a bad connection on the right arm electrode won't just affect leads involving RA, like I, key, and AVR, but because the limb leads form the reference for the chest leads, Wilson Central Terminal, it can actually introduce artifact across all 12 leads sometimes.
Wow. Okay. So troubleshooting artifact is a skill in itself.
It really is. But again, it comes back to those fundamentals. Understand the placement, understand the conduction system, understand the basic waveforms. That gives you the framework to interpret what you're seeing, even when there's noise.
And the 12-lead system is so valuable because it gives all those different angles on the heart's electrical activity.
Exactly. It's like having multiple cameras looking at the heart, giving you a much more complete picture than just one view alone.
Right.
It remains an incredibly powerful standard diagnostic tool.
So as we wrap up this deep dive, what's a final thought for the medical student listeners trying to master this? Something to keep in mind as they look at those tracings.
I think it's appreciating that this simple-looking piece of paper, the ECG trace, tells an incredibly rich and complex story about the heart's electrical function, second by second.
It's more than just pattern recognition.
Much more. It's about understanding the why behind the patterns, the electrophysiology. Mastering the ECG is truly indispensable. You'll use it everywhere, from routine checkups to critical care emergencies.
So the provocative thought is maybe, how does this electrical map truly reflect the heart's health and predict potential problems?
Yeah, and how can you get better at reading that map? My best advice is look at as many ECGs as you can, especially in the context of real patient cases. Case-based learning is where the theory really clicks and becomes practical skill. Don't just memorize rules. Understand the stories the ECG tells.